quality of life is one of the things that I most probably. I want to see if anybody else wants to go to this group.
Good afternoon, everyone. I know we got the difficult slot directly after lunch, but I also know that the session ran over and people are running back from lunch, so I'm hoping others will join us. So, firstly, to introduce myself, my name is Teresa Glynn. I'm Development Executive for Heart Valve Disease with the Global Heart Hub, and you heard Neil Johnson speak about our organisation earlier. In terms of heart valve disease, it's a common, serious, but treatable condition, and it's primarily focused on aging, particularly affects people of aging. 1 out of 8 people over the age of 75 are currently expected to be living with heart valve disease. We expect that to double by 2040 and to triple by 2060, so it is a significant concern, and it is believed to be the next cardiac epidemic. So I'm delighted to be joined by experts here today who are going to share their experience and expertise around the topic of heart valve disease. So we have Dr. Stagmo, who you saw earlier on the stage, Country Medical Director with Bayer Sweden and a Fellow of the European Society of Cardiology. We have Näumann, he's the CEO of the German patient organisation initiative Herzklappe. And we have Suzanne, who's the Managing Director of Health Policy Partnership in the UK. And as I said, I'm going to moderate this session. I'm going to hand over to Martin in a moment, and what we're going to do is maybe for the next few minutes get a brief insight from each, and then we're going to have a time for Q&A and a panel discussion. So, Martin, if you'd like to.
Thank you very much, and thank you for inviting me. I'm just going to give you a very short overview of what is heart valve disease. And we spoke earlier before this session, and I've said that heart valve disease is a bit of a neglected disease. And I think one of the reasons we don't see many people in here is because people don't know about heart valve disease. People don't know what it is. People don't really know why this is important, but it really is. I've been working with heart valve disease for 25 years, and I think it's really fascinating. And also the way that the treatment of heart valve disease has developed over the last 20 years is fantastic. But it's still underdiagnosed. It's still undertreated, so it still needs to be increased awareness in the society. First of all, just to let you know, what are we talking about? Heart valves, they are no back valves. They are valves that make the blood only through one direction. So if the blood's trying to flow the other way, the heart valve will close and prevent that. We have 4 heart valves, 2 on each half of the heart, because the 2 parts of the heart, they work in a series. They do not work parallel, they work in a series. So whatever blood comes in, they have to go out through this valve, and then through the lungs, back to the left side, and then through into the aorta, and then all the way around. So the valves are there to open when the blood needs to come out, and close when the blood shouldn't go the other way. And we have to remember that the heart valves, they start working even before we are born, just when the heart is being formed. And they open and close once every heartbeat. So they are subject to a lot of wear and tear. Sometimes I actually think it's amazing that they work as well as they do, since we are, I don't think we were designed to be 80 years old, to be quite honest. So I think in a way it's even more fantastic that they do work. But sometimes they stop working or they work less effectively. They can either be stenotic, where they don't open as good as they should. Then the heart has to work harder to push the blood out through these stenotic valves. Or they can start leaking, which means that the blood flows the wrong way. And then you have a volume overload of the heart. So both these things can contribute to heart failure, and that's what mainly gives you the symptoms of heart disease. As I said, we have 4 valves. That is mainly the 2 valves from on the left side of the heart, which is like the main engine of the heart. The right side of the heart has a very easy job. It only has to push the blood through the lungs. But the left side of the heart has to push the blood all the way through the body. So it's the aortic valve that's placed at the beginning of the aorta, and the mitral valve. It calls the mitral valve because when the surgeon looks at it, it looks like a bishop's mitre, the hat that the bishop has. So these are the two main valves, but you can have diseases in the other valves too. Just so you know what is valve disease. We can have the next slide. So how would you diagnose this? Well, the most important thing is actually to always have a suspicion that there might be valve disease, especially if a patient comes complaining with fatigue or shortness of breath or angina. But really, the easiest way, Näumann invented the stethoscope in 1860, and I mean that's the telltale sign for a doctor, white coat and a stethoscope. And really, you should never have a physical examination in a healthcare facility without having listened to your heart. We do it to all the newborns. The neonatologists listen to all the newborns a few days after birth to see if they have congenital heart disease. But even higher up, we should always listen to the heart whenever we are consulting a doctor, unless we are, of course, going there repetitively, because then we've done it once maybe. Because this is the first way of detecting a heart valve disease. You will have murmurs. You will have murmurs because of the altered blood flow through the valves. So if you listen to the heart, you quite often will be able to diagnose a murmur. Then you have to go on to do a more specific examination, quite often an ultrasound examination or echocardiography. But that's the next step. Then you can actually pinpoint exactly what valve is deficient and how severely diseased is it. If you have a valve disease, let's say you have an aortic stenosis, a stenosis of the aortic valve, or a mitral regurgitation, a leakage in the mitral valve, then you have, let's say, 3 different options. You can have what we call watchful waiting, where you actually, we know you have this condition, it is not serious at the moment, we don't know if it will be serious or how soon it will be serious, but we will have to follow this up at regular intervals. So that's one thing. But then you really need to know what are regular intervals and what should I as a patient do if between the regular intervals my symptoms get worse. So I don't just wait there, because then there's not watchful waiting anymore, then it's something else. And if you decide that, okay, we have a severe heart disease here, there's normally 2 options. Either you do open heart surgery, which is the traditional, where you actually either repair the valve or you replace it with a mechanical or a bioprosthesis, which is a valve that is often taken from a bovine valve or a pig's valve. But it can also be a metal valve. Or you could do what Stefan Gates talked about before. You can do it without open heart surgery. You can introduce valves through the big arteries and actually expand them. And this is a field that has grown very much in the last few years. So we do have a big spectrum of different valves suited for different patients and different conditions and different techniques, which is really, really important. But if you haven't diagnosed this and if you haven't decided what to do, then you will never get access to this. So this is really, really important. So it is quite prevalent and it increases with age and the way we get older. And it can be dangerous if it's not treated early, but there are a lot of treatments to be done, but then you have to diagnose this. That's a very, very brief history of heart valve disease and heart valves. But any comments, thoughts about this? Does it make sense? But remember, you can have severe heart disease without having any symptoms yet. So then somebody else needs to diagnose it for you.
Thank you, Martin. That's perfect, and great to get an insight into what the condition actually is and how you can diagnose and what the treatment options are as well. So from a patient perspective, Jens will ask you to share a few thoughts.
Yeah, thanks, Teresa. Well, from a patient perspective, I think there are a lot of obstacles and burdens along the patient journey. So I think one of the main challenges is to, as a patient, to identify and to admit and also to detect that you are a heart valve patient yourself at all. So there's a lack of knowledge, like Martin said, about symptoms and about heart valve disease in general. So in 2018, I first realized that there could be something wrong with my physical condition. So what cardiologists later on told me was that it was very urgent, it was high time, it was almost too late. At that time, I couldn't do any physical examinations, it was just impossible. When I was riding a bike, like you said, I couldn't breathe, I couldn't keep up with my wife when cycling, and this was kind of strange for me. And what I did is, and this is something which is not what was not mentioned yet, is what I did is, a lot of people do that, they deny their symptoms. They just don't realize or just want to realize and admit that they have symptoms, and that could be dangerous. So, well, the main thing with the symptoms I had was that they came irregularly. They were sometimes worse, sometimes less bad, and they came gradually over a long period of time. So it was very difficult for me to identify them, and yeah, because we get used to them, and it is also very difficult to connect them to a fatal disease, because we don't know anything about it. Well, I didn't know anything about it. So yeah, today I know I should have asked my GP for a stethoscope check, because it's the first thing that you need, of course. But I don't want to blame her, but you know, she never auscultated me in a period of 10 year time. So when she retired, her successor, you know, immediately referred me to a cardiologist, because yeah, it was severe, it was urgent, and I was diagnosed with a high-grade aortic stenosis and insufficiency. And the combination of both, and that was a shock for me and for my family. I'm married, have 2 kids, so that was quite hard for me. Right, but I'm standing here, so I'm healthy, everything is fine, but at that time everything went very fast, very quickly. Just a few weeks later, I was implanted with a mechanical aortic valve, and yeah, it was high time and I was lucky. I think a lot of people experienced the same thing as I did. They are simply not aware of the symptoms, and they do not know anything about heart valve disease. A few facts and figures from Germany: just 6% of seniors, 65 plus, which is the most, or who are the most affected age group, know the definition about aortic stenosis, and just about 50% would see a doctor due to dizziness, fatigue, lower performance, and shortness of breath, and are much more concerned about cancer and Alzheimer's. So this is kind of a problem, I would say. Yet an untreated aortic stenosis, you mentioned that before, leads to death within 2 years in every symptomatic patient. So this is quite a number, and it's incredible, and there should be something done, and this is my mission, I would say, as a patient advocate. So today, 4 years after my treatment, my wife cannot keep up with me on the bike, which is good news for me, but not for her. So I feel healthy. I have left the painful and sometimes rocky patient pathway, which I almost didn't start, and I think this is the main point. In order to be able to start or to embark on the patient pathway, there has to be an awareness of the disease and its symptoms. Not only amongst general public, but also among GPs, and I think this should be the main thing. Yeah, I'm here today. I'm living a normal life, a happy normal life without any restrictions. I have to take anticoagulation, but it's no problem. And yeah, that's just a quick overview of my biography as a heart valve patient. If you have any questions, please feel free to ask.
Thank you, Jens.
Later on.
Yes, absolutely. And we'll definitely come back with questions. I think really nice to hear the patient perspective, and obviously Martin has talked about the clinical perspective. So we're going to talk to Suzanne for a few minutes in terms of the policy aspect of this. And Jens mentioned, the patient journey, and this is a project that we worked on together for quite a while. So
thanks, Teresa. So in listening to him, so we've heard Martin talk about this is an area obviously that's increasingly frequent, and you referred to this as well, but where there's been fantastic innovation, extraordinary innovation, and where something can be done. And then we've heard Jens talk about the patient pathway, and again, the needs, I think, of individuals, and as you say, you were a lucky one who benefited from the innovation, and thankfully it was late, but it was in time. But I think the reality of heart valve disease, and we've said this already, it's a very, very unknown and misunderstood condition by the general public, and politicians are the general public, so, by policymakers as well, probably by non-specialist physicians as well. And it's a growing public health concern, and it's an area where things can be done. And that, I would say, is almost like a perfect storm for action at a policy level, because policymakers don't like just hearing about problems, they like problems to which there are solutions. And this is a problem to which there is a solution. So anyway, that's the backdrop. So my lens is policy, and I was very fortunate as, for my organization, the Health Policy Partnership, we worked in partnership with the Global Heart Hub, many people who were in this room, so Jens was part of the project, as was Teresa, as was Suzanne. Later we worked with Ellen, anyway, and our goal was to say, how do we depict what good looks like in terms of the patient pathway for heart valve disease? And how do we start with that, like this goal in mind of what good looks like, and then try to take a multidisciplinary perspective on what needs to happen to achieve that ideal. And do it at a European level, so that this is almost a starting point for policy engagement and also for advocacy. So that was sort of the remit that we had set ourselves. And you're sitting on, or you nearly sat on one of the outputs of this project, and there's a full report that's over there. But the importance is not just that we developed a report. What was really interesting, and I mean, I do this day in, day out, but I love this project because we sort of achieved everything that we're supposed to achieve when we do these things, is first of all, we said we need to take the patient perspective as like our guiding light for this whole process. And we need to always think what's important to the patient, what's important to the patient, and actually not what's important to the patient, what's important to the person. It's not, I hate that term patient journey, because it's not a journey, and the pathway I think is a much better phrase, but it's not a patient pathway, it's actually a person pathway. You're a person who gets a diagnosis, as Jens was saying, right? And then you suddenly become a patient. No one chooses to become a patient. And you don't want being a patient to define your life. You still have all the other factors of your life. What you were saying, Jens, is, this isn't the only outcome, but the fact that you can ride your bike and you beat your wife was a tick the box, right, for you. But that's really, really important to keep in mind. So everyone starts off as a person and continues to be a person, obviously. So the patient journey, if you like, the patient pathway, had to start at that point of what do we need to do to raise awareness? What do we need to do to make people realize what heart valve disease is for people who were potentially at risk of heart valve disease, for them to be aware of the symptoms, to ask for help, to push their physician if needed, to have a stethoscope check, to be referred to an echocardiogram, et cetera, and then what needed to happen within the whole complex, often fragmented healthcare system. We all live in different healthcare systems, to make sure that all the relevant professionals work together for the good of the patient, to try to make sure that that patient had access to optimum diagnosis and treatment, and everything involving the aftercare, the monitoring, the follow-up, the psychological support. So that was sort of the lens that we took on this project. The other thing I think that was so interesting is when you do something at a European level like this, it's a little bit of a question of compromise, but not in a bad way. So I'll give you a specific example. One of the things that we were very mindful of is we didn't want to have sort of wishy-washy recommendations of, you need to pay attention to patients' quality of life. Well, no kidding, right? Everyone's going to go, yeah. If you want to get the attention of policymakers, and actually if you want to empower patient organizations or other stakeholders to actually ask for something that's concrete, it really does need to be concrete. So one of the things that we really wanted to bring into the recommendations, and which is in there, is the notion that you need a timed target, if you like. So for example, if you are someone who has been auscultated with a stethoscope with the possibility or the detection of a heart murmur, you need to be referred to an echocardiogram within a certain amount of time. Teresa, you were saying earlier that in a study of Ireland, some people wait 2 years for an echocardiogram. 2 years that's the first point of diagnosis, right? So again, you need to say every patient needs to receive and not be referred for an echocardiogram. Receive an echocardiogram within a given period of time. But at a pan-European level, figuring out what that time should be was very tricky because in different countries, there are already different targets that exist. So you sort of, when you do it at a pan-European level, you can set the principle in motion that it needs to be a timed pathway. But then the next step from that is for each country, and it's being done in Germany, it's been done in Canada, it was done in Ireland, to think, okay, how do we translate this into the reality of our healthcare system, of our patient advocacy experience, of the various pressure points, the capacity, what kind of, do we have multidisciplinary care teams available? What kind of professionals do we have? Cardiac physiologists, for example, don't exist in some countries. Nurse specialists don't exist in some countries. So making those recommendations, taking them as a starting point, and really anchoring them in the reality of what should be done and what can be done. So I think I have no idea how long I've spoken for, I'm sorry. But I'm gonna stop. Okay, but essentially, I think the thing that's been really, really nice with this report is that it didn't end up being a report that sat on the shelf. It's been a starting point for patient advocacy engagement, in great part thanks to the leadership and the continued leadership of the Global Heart Hub and all the Global Heart Hub's members and affiliates, and to the professional community that's come together with us. And it's also been a starting point for policy advocacy, and obviously those efforts need to continue.
Thank you, Suzanne. So I think this was a really good snapshot of the clinical, the medical side of things, the patient aspect and the policy piece, and we could spend hours on all of those topics. But we have a few minutes for a panel discussion, but I did want to open up and see if there are any questions from the audience.
Apart from the fact that our population is getting older and older, is there another explanation for why this disease is expected to increase so much?
No, I think the main reason is that we are getting older, because as we get older you have the degenerative valve disease, but also because we actually manage to maybe survive better. So we actually get a heart valve replacement, but that valve needs to be checked regularly because that will be replacement after a while. In some cases, not all cases. And also I think because we do see as we get older we get more problems with infections that can cause heart, like endocarditis. But I don't think there's anything else that we know of. It's mainly that we are actually getting older. We used to die of other things before we had the degenerative heart valve disease before.
Thank you.
But it's a good question. It's interesting.
Any other?
Yeah, you were talking about the European patient pathway. And I'm also thinking the differences within the country. So I work for Medtronic and within TAVI. Yeah. So obviously I've looked at the differences in how many TAVI treatments they are performed per million inhabitants. And then here we have Germany, best in class, present. And I mean it's big differences. Germany had like 300-400 per million inhabitants, and UK and Ireland not best in class. But how to sort of, I don't know, work on that is that, I mean, maybe the German numbers maybe are not what we should aim for. I'm not sure. No one knows really, the answer. I would say what's reasonable, but just interesting to see if there's the European take on that as well. I mean, it's so different.
Can I just share this? But we did discuss that a lot, and I talked to Tabby, and I mean, there's so many factors that come into play, right? So one of them obviously is willingness to pay and cost, or perceptions of cost. I think there's a lot of focus on the immediate cost of Tabby versus the longer term whole kind of system costs. There are lots of studies that show that getting Tabby maybe has a bigger upfront cost, but from a quality of life perspective, and longer term cost, the overall cost burden is actually lower. And obviously cost should not be the only thing we look at, but it is a kind of hand up, I think, in a lot of countries where they're like the cost is too high. So it's a question of prioritizing within funding and advocacy for appropriate funding. And then the difference is also, I would assume maybe due to competencies and training, of the surgical, not the surgical, but of the
Oh,
the
definitely,
workforce.
but the surgical too, actually, because in my view, it's not a matter of do we have enough TAVI or enough open heart surgery. It's a matter of actually having all the available treatment techniques that suits the individual patients, and we're getting back to that. And that depends on what you're actually comparing with. If you have centers with a very, very good technique in TAVI, you will have very low complication rates. If you have centers that are really, really good at open heart surgery, you will also have low complication rate. So in the ideal world, you should actually look at both the competencies and also all the available techniques and then choose the one that is right. So you can never say which is the right level. But of course there are guidelines where it's definitely preferred and when it's not preferred. And of course there are a bit of a discussion between surgeons and TAVI operators that you can interpret data differently. That's the way it is.
But it's, if I may also, I think like with any innovation, and I mean this is one area, but in a lot of areas where you move from an open heart surgery model to a paradigm where there's a less minimally invasive surgery, not surgery. I mean, I know surgery is also minimally invasive, but transcatheter surgery. There has to be some kind of shift in the whole system, doesn't there? It's not just a shift in intervention; it's a shift in. I mean, that picture that was shown this morning was just amazing, right? What postoperative means, and then the needs of individuals who've gone through the two interventions are going to be very difficult. I would imagine the composition of the clinical teams, or the priorities for the clinical teams are going to be different. So I think also it's taking that systems approach and thinking, okay, well, if we are going to introduce this, let's do it properly, and let's gear up. It's not just a question of ticking the box and having the intervention available. It's making sure, as you say, there's a critical mass of interventions performed so that the quality levels are high enough, etc., etc.
But also discussing with the patients, what are your expectations, what are your needs? Do you want this to be the only intervention you have? I don't ever want to be in hospital again if I can avoid it. Then you have one kind. If I say, I'm all right to do this less invasive, I might come back in 10 years and do another one, that's no problem. Some of them will say, even if you are younger, I'm an extreme sport athlete, I cannot eat anticoagulants. Then you have to change it. So it's a lot of, you have to discuss it a lot with the patients because your choice has implications.
Yeah, but the patients have to be informed.
Yeah.
And it's difficult to inform. So this is where we come in. So that's true. Yeah.
And you have to paint the picture for the patients. If we choose this, it has disadvantages and this disadvantages.
Yeah.
But that is great that it's really emphasized from the European guidelines from 21. Really, the patient should be a part of the decision, and also the heart team approach. I think those two are super important. But I don't know how much, if it is really implementable all over, probably not. So that's something I think we should also really try to reach.
I think it's a process. It's a change, so it takes time to implement it. In Germany, a lot of patients, they don't realize that they have a voice and that they can decide as well what is good for them and what is not good for them, or what their life should be after the surgery or the intervention. So I think it's a process, and in Germany, the elderly generation is kind of it's difficult to convince them that they should prepare for appointments with the heart team or with the doctors or physicians. So it's a process, I think. And this is kind of part of my job as well.
Maybe to that point, is if somebody came to you today that had been recently diagnosed, what advice would you give them based on?
Many advices, but maybe the important ones, or most important ones, is inform yourself. Inform yourself after the first or at the first day of diagnosis. So become your own expert for your disease, because you know your body, you are responsible for yourself, and you have to, on an eye level with the physicians, you can't be, because there's information asymmetry, but try to do your best and prepare. So don't panic, trust your doctors. It's a big thing for the patient. I mean, open heart surgery, it's crazy, but it works. But it's routine for the surgeon, and this is something you should realize. It's a big thing for you, but it's not like a very rare disease or something. it's treatable. So don't panic and prepare. And bring your, I don't know, family members, your loved ones to the appointments, to 4 years here more than 2, and you're sometimes overwhelmed with this diagnosis, so and not concentrated. And it's also, let me say that, I think it's an important point, physicians, sorry to say that, they speak often another language. They seem to speak another language, and you don't understand it, you are not a physician. So ask until you understand.
I think a newly diagnosed patient would be very lucky to meet you and get all the good advice. And maybe I'm looking at time, and I'm sure somebody's going to knock on the door soon, but a couple of other questions maybe before we start to summarise. So maybe Martin, on your side, in terms of awareness of heart valve disease in the Nordic region, both in the general public and in the medical community, what's your perception of that today, and what do you think?
I think it is low in the general population. People know about heart failure, they know about ischemic heart disease. They don't know about heart valve disease. It is taught in all medical schools, of course, but I think we are still forgetting it, especially if you're a GP, because you don't see that many patients. You see so many other patients. You don't see them with heart valve disease. But I mean, I've been teaching at medical schools for many years, and I was taught you haven't performed a complete physical examination unless you have listened to the heart. So that's very easy, and it takes 2 minutes. Now we are not as good as listening to hearts than my father-in-law was quite a famous Swedish cardiologist. He's 87 now, and when he listens to a heart and he describes that's like he describes a piece of music. So he's much better than we are. But again, because we can use ultrasound to actually check what it is. But we have lost, I think, some of the skills of doing it. But still, we should do it all the time, and even in primary care. Okay, if you meet your primary care physician every 6 months, you might not have to listen to the heart every time. Maybe once a year or every 2 years. As you said, 10 years without it, that's too long.
Definitely, yeah.
And I think it's, this is common in other countries as well. It's really the partnership with patient organisations like in Germany that can really help advance that in terms of patients or people asking for stethoscope checks and making sure that they're comfortable and knowing to do that, as well as GPs being informed as well. Maybe a question for you, Suzanne, as well, in terms of, I suppose you gave a really good sense of the work that was done in the patient journey report, and in terms of any kind of lessons learned and the strategies that were used that you would consider sharing for others for the future.
I think the one is to have a plan. So, it's not about developing a report, it's about knowing how that report's going to be used. And also, I think that was really quite unique is to really get, so for example, if this were going to be applied in Sweden, to have real leadership from the patient community, or patient communities, depending on what the configuration is, who have a plan to use this concretely and to use it as a platform for engagement. That would be one thing. The other thing is, I think, really making sure you have everyone in the room who needs to be in the room, obviously patient representatives. I mean, one failing that we had is that we actually didn't have anyone from primary care. We tried, but we didn't ever have anyone from primary care. And at a European level, it's difficult because primary care is so localized. If you're doing something at a national level, for the reasons you were saying, Martin, having someone from the primary care community is so vital to drive change, because driving change at a policy level means giving a steer to change things in practice. And actually the two are bi-directional. So really having the right people involved.
From the beginning.
Yeah.
Excellent. So I'm looking at the time, and I think we probably need to move to maybe key takeaways. So we launched a little slide, but I'll ask you maybe, Jens, if you want to speak to your key takeaway from the work we've been doing in terms of preparing for today, and what you'd like people to take away.
I mean, it's a takeaway from the patient pathway report, as well as from my perspective as a patient, is that personal learning, so to say, is heart valve diseases, they're common, but they should be taken seriously, but they are also treatable. And when treated, lead the living example to a longer life and also a higher quality of life. So I think this is one of my main takeaways, messages.
Perfect.
learnings.
And in terms of Suzanne, your takeaway from this session?
So I've forgotten what I was going to say, but I'm going to say what I need to say, which is that I think we should never take what matters to patients for granted, even as a physician, even as a patient representative. Obviously, there isn't a patient, but it's important. What you were saying was interesting, Dan, is that when a person is with their doctor, the doctor is the expert, and thank God, the specialist expert. But there's no, what is going to matter to that individual, what they want to know about this intervention is going to be very different depending on your life circumstances. And of course, good doctors all know that, but I think, if all of us have been a patient, and you just become a different person. You get scared, the questions that you had prepared at home go, and so I think we should never take that for granted, and that what matters to patients, we should always interrogate ourselves about whether we're really doing things in the interest of the people who are the patients. That's one of my take.
Yeah, mine is the last one actually, to have early diagnosis, to be able to see this could be a problem, and then rapid access to maybe not only treatment, sometimes just to somewhere to discuss what should we do. Is this something we don't need to worry about at all? Is this something that needs to be followed, and at what intervals? And then discussion with the patients. And also I think another one important thing is taking the patient perspective, because I've had patients who've said that I don't want to know anything, you just do what you think is the best. And they are quite happy with that. They are really not interested in having, and then I have patients who want to have every detail of everything that's going to happen every day. And you have to actually accept that, because we are different. We are different, all of us. And I think that's really important. And I don't like it when we say that it's up to the patients to choose. No, that's not fair, because the patients, as you said, don't have all the, but it's up to the patients to be part of the discussion. And then I need to say what I think from my professional knowledge and my experience would be the best, and these are the reasons. And then we can discuss if I got you right or not.
Yeah. Okay.
Thank you, and I think, we could spend a lot longer here today, because I think there's so many learnings and experiences and insights that we can all share, but hopefully this gave everybody a sense of what heart valve disease is all about, what to think about from the patient perspective, from the policy perspective, and from the clinical perspective. And what's really important is asking for that stethoscope check as the first step to getting on that journey, on that pathway. So we're going to come to the end of the session. All of you will see, or people that are here, you will see we have some handouts on the chairs, so please feel free to take them away. If you have any more questions, I know, Martin, you need to run, but we may be here for another few minutes. So if there's any other questions that you might have that we'd like to do. So thank you once again for coming along to the session, and thank you to Focus Patient for inviting us to be a partner on this special day regarding cardiovascular disease.